Hey guys, my name is Lopez. I am a board certified wound care specialist. I'm also board certified in family practice as a nurse practitioner, and I'm an adult gerontological acute care adult nurse practitioner. So I've been in healthcare for over 23 years. I've been doing wound care for over 23 years. I started in 1998. I first started with my associate degree in nursing, got my bachelor's, got my first master's, got my second master's, and in between somewhere there, I got board certified for wound care. So wound care is my passion, and I know you guys have a lecture today on wound care, so I'm trying to do a little video for you guys, something that is objective, something that is practical regarding on how wounds heal. So let me start with the general idea, and I sent you guys a PDF. I think you guys can follow there. We're going to review your learning objectives. Basically, we're going to cover perfusion, non-viable tissue, inflammation with or without infection, edema, wound microenvironment, tissue growth, offloading, pain control, and host factors. I speak real fast. I think that, we all have the same 24 hours in a day, and I've made 30 to 32 hours of my 24-hour days by moving quickly when I can. So good thing is you have the video so you could hear it over and over. And this is more of an actual hands-on, more of a practical approach to wound care. You remember, for boards, you guys have to follow what your professor's telling you, because that's what's going to be on boards. With my experience and everything that I've done, I have a more practical approach, and as an advanced practitioner, I can actually diagnose and treat. So y'all's focus is a little bit different, but I want you guys to take some very important takeaways from this lecture, because there's some things that are going to impair the patients from healing, and that's kind of what I want you to look out for. Remember one thing, let us make no mistake, nurses are the eyes and ears for the patient. We let the doctors know what's not working. We let the advanced practitioners know what's not working. So never, never, never underestimate the power you're going to have as registered nurses out there doing these assessments, letting these doctors know, hey, I'm sorry, I need this, I need that. So there's some things, and this is not working, right? We are the safety net for these patients. We are the patient advocate. So don't forget that. And take great pride in being a nurse. I take great pride in being a nurse. It is my nursing background that has made me the advanced practitioner I am today, and the wound care specialist that I am today. So very, very important, if you follow the first issue that I'm going to discuss, is adequate perfusion. So remember one thing, if you don't have good plumbing, guys, you're not going to get blood flow, you're not going to get any healing. So it's very important that you make sure the patient has adequate perfusion. What is claudication, cramping, pain, or tiredness of the calf, thigh, hip, or while walking? There's going to be diminished extremity pulses when you don't have adequate perfusion. And then you're going to have some tissue loss. At that point, you're going to have a wound that potentially is not going to heal. Very, very important. Wounds that are not healing in extremities are probably not adequately perfused. So what are you going to be looking at? You're looking for adequate perfusion. If you can read in the first bullet point, occlusive atherosclerotic lesions developing the extremities or peripheral arterial disease is evidence of a systematic atherosclerotic process. Very, very important that these patients get referred to cardiology, so keep that in the back of your mind. The prevalence of PAD is 30% in patients who are 50 years or older, who have diabetes, mellitus, or a history of tobacco use. So in those patients that are diabetic or that smoke, you're going to keep an eye out a little bit closer, okay? What is the epidemiology and impact? Framingham's heart study suggested that 20% of symptomatic patients with PAD also had diabetes. So very important. Somebody with a non-healing wound that you suspect peripheral arterial disease, maybe they're going to be diabetic. So make sure you let the doctor know, and they need to work them up for diabetes. Over half are probably asymptomatic. 1/3 only of the patients have claudication, and the remainder have more severe forms of the disease. So don't forget that. Also, the second bullet point probably underestimates the prevalence, as more people with PAD are asymptomatic than symptomatic. The tough part about PAD is you don't feel it until you have a black toe. So that's not a good thing. That's why health and wellness is very important. Prevention is very important. We go on to the next bullet point. All of these pictures that are within your slides, guys, are my actual patients that have healed. Praise God. I give God the glory, because he does the healing, but we put in the work and the expertise and the wisdom, and we have to study to make sure we understand, because we could be the one that's going to help that patient heal by speaking up when something's not working, or by suggesting the right modalities. So attention in the diabetic patient. There's a far greater chance of PAD in patients that are diabetic versus non-diabetic. There's a far greater chance of concurrent venous disease, so we're looking for venous and arterial disease. Far greater chance of ulceration leading to amputation. Stop amputations. We got to be the voice of these patients. We got to be patient advocates. Don't let people's legs get amputated. Prevent, prevent, prevent. There's also a far greater chance of requiring a second amputation within a short period of time. So that's why we want to try to heal these wounds out. And if you look at that patient, praise God, the patient's one of mine, of course, and they're healed. Okay, look at the before and after. Y'all can zoom in. So refer early. Refer early, guys. If the patients are having pain, if the patients are having cold extremities or feet hurt, we got to refer early to save a limb, because you're going to save a life. You look at the general fun facts about fast facts on diabetes. 29.1 million people, or 9.3% of the U.S. population, have diabetes. Furthermore, what about those that are undiagnosed? Okay, if you look at the racial and ethnic differences, you see very quickly in the graph that non-Hispanic whites have a lesser chance than American Indians, Alaska Natives, non-Hispanic blacks, and Hispanics of getting diabetes. So that is a discrepancy. It's a disparity in our population, right? We have a higher risk if you're a Hispanic or black. Amputations in 2010, 73,000 non-traumatic lower limb amputations were performed in adults 20 or older diagnosed with diabetes. Very, very important, guys, that we try to heal these wounds out to prevent these amputations. And diabetes costs in the United States in 2012, $245 billion. So very important that we try to minimize cost, because this is, in fact, our healthcare. We want to help heal patients faster, control diabetes, and therefore help the overall population. Deaths among people with diabetes, 69,071 death certificates had diabetes as the underlying disorder. A lot more fun facts that I added there for you. Very, very important. Diabetes is not a happy disease. It is not good outcomes. It is the leading cause for ulcers. Let's go to number 2. So we talked about PAD. Perfusion. Point 1. Point 2, non-viable tissue. Guys, if you see that black, that's not my patient. If you see that black, dry, hard scar, that wound is not healing. Contrary to what some people think, the scab is good, the scab is bad. That patient needs to be debrided. Now, this is all advanced. That patient needs debridement. Wound healing is either delayed or prevented in the presence of revitalized or contaminated tissue, which is eschar. There must be removal of necrotic tissue to allow normal healing. Okay, you want a beefy red wound. You need to address that. Now, inflammation and infection. Wounds with bugs don't heal. Very, very simple. Gold standard is a biopsy of the tissue within the wound. We no longer do just swabs of that dirty. You see already all that discharge. That's also not one of mine. You don't swab that. So the way you do proper cultures is you take everything off and you let the practitioner get a punch biopsy or a tissue biopsy. I usually cut a piece off of the skin and send it off for culture. That's actually what's going to help me guide my wound antibiotic treatment. Okay, so we don't start up antibiotics with a culture. So if your practitioner, your doctor, your nurse practitioner, PAs about to start an antibiotic, say, hey doc, ma'am, would you like me to get a culture of this patient? You want to go ahead and take a tissue biopsy from me so I could send it off? Remind them, because they forget. Edema. Wounds are not going to heal if the wound is swollen. So very, very important. If the leg is swollen, we elevate the leg. After we've checked circulation, we do some compression stockings. Very, very gentle. I just do very gentle ACE bandages. Very important, guys, as nurses, pay attention, please. We have to wrap that bandage from the toes all the way up to below the knee so we can get all that fluid. A little caveat, a little side note. When patients have congestive heart failure, all of that third spacing is going to go where? Back into the intravascular space. High risk for a CHF exacerbation. So keep an eye out for that. Narrow down the etiology for the edema. And of course, that would be by the practitioner. They need to go see cardiology or they need to get worked up and treat accordingly. And we have to check medications. Possible treatments, compression, massage, vascular interventions. Never massage a patient. Please, as a nurse, you don't massage patients. Even as practitioners, we don't massage patients. They could have a DVT, then you're going to have a PE. Okay? Don't massage patients, but this is under the care of a practitioner. We may refer them to physical therapy for massage. Okay? Wound microenvironment, number 5, very important. What are we measuring? Look at the measure. Okay? M, measure. E, exudate. A, appearance. What is exudate? What's coming out? The liquid. Appearance, how does it look? S, suffering. Does the patient have pain or disability? U, undermining. Undermining is when there's a skin, it's open, and this is not stuck to the sides. There's undermining under the skin, kind of under here. That's undermining. You can Google that. And then reevaluate the patient. Look at the edges. The wounds are not going to heal unless the environment is conducive to healing. So those are the kind of like the things that we're looking at. Okay? The amount of exudate, there's suffering. So you have to address each of those areas. If we don't address each of those areas in an advanced way, the wound is not going to heal. Tissue growth is optimized. Enhanced tissue growth, there's different methods. There's bioengineered tissue. I here in my practice, in our wound healing center, we do apply live skin cells. They are skin substitutes based on the insurance. And based on the type of wound, we can also use negative pressure wound therapy, which is a wound vac. That's the most common name, but there is negative pressure dressings. It's a little sponge that goes in there. You can Google that. and it helps heal the wound faster. Or you can also put the patient in hyperbaric oxygen therapy, and that's going to help the patient heal faster. This is one of our patients. I'm very, very proud of this patient. He has since passed. But before he passed, Mr. SD healed out with us at least 5 to 8 times of very, very horrid wounds. And this is a coccygeal wound, okay? Lots of debridement, lots of follow-up. All of our patients do see me every week. This is another patient that also healed out at least twice with us. We did not allow them to cut off her whole leg. She just got a TMA. It looked a lot better than this on the far right. This is just when she was almost healed, but she did completely heal, so we're very happy for her. This other patient also healed. He's a young man. That's before and after. It finished healing out all the way. That he still has a little bit of an opening in the top in the dorsal area. But he, as you could see on the before, there was tendon and bone exposure. Non-compliant diabetics, all of these non-compliant diabetics or uneducated diabetics, okay? He did heal already. And then this is another one of our patients, okay? Same thing, lots of debridement, lots of good follow-up, wound microenvironment. Very, very important. That's a before and after. So now we go to offloading, okay? You cannot heal a wound if you're putting pressure on the wound. So that's why bottom wounds, if they have a hole in the butt, they're laying down on the bottom, the coccyx and the gluteus, it's going to keep getting bigger. They need to offload the patient. That's a good way to offload a foot. The best way to do that is to do an offloading shoe, okay? Pain control. Guys, if the patient's not in without pain, they're not going to move around. You need to move around so you could heal, okay? And it's also going to minimize you from deteriorating in other areas of your body. Number 9, optimizing the host factors. What is a host? Well, the host is your human body. The host is your patient. So you have to look at everything. Nutrition, very important. We have a certain vitamin regimen that I put my patients on. You have to control the diabetes. You have to look at the kidneys. You got to make sure they're mobile, that they're getting physical therapy. Make sure the other systemic diseases are addressed, the high blood pressure, the rheumatoid arthritis, the depression, the anxiety, and psychosocial issues. Get the family involved. Make sure this patient has a good spiritual support system, going to church, reading the Bible, singing, listening to praise and worship. And if not, let's intervene. All of those are very, very important. Those are my references. That is our contact information. Yes, I share my cell with everybody. Everybody has my cell. It's on Facebook. We have a public page on Facebook. We're actually going to be having we do a wound care conference once a year. We had to postpone because of COVID. So this is just a little bit of the information that is shared in the wound care conference. I hope this was helpful. It was fast, but you have the recording. I don't bore you, and everything I give you is beef. I know you guys are students, but this is something that you can refer to my PowerPoint, and you can always email me if you guys have any questions, and I hope you guys enjoyed it. It's late. I've seen a lot of patients, and now I need some rest. So hope you guys enjoy the PowerPoint, and y'all take care. Bye-bye.